Hello everyone. Today we will discuss about one of the most important thing, that is about usage of steroids in clinical practice. Steroids. So we will deal this section in the following headings. First is equivalent dosages of various steroids. Equivalent dosages. Then comes what is the rationale behind usage of different steroids, that is what is the exact mechanism of action of various steroids. Then comes the dosage, and finally some special scenarios. Here we will cover what is pulse therapy, what is the stress dose, steroid. So all these things. So we will deal one by one now. First is about equivalent dosages. Here Dexona or dexamethasone of 0.75 mg, roughly we can consider it as 1 mg. This is equal to methylprednisolone of 4 mg and equal to prednisone or prednisolone. Only difference between these two is, this is we can consider as a preform. Whenever we give prednisone, it will require liver enzymes to get converted into prednisolone, which is the active form. So when there is severe liver injury, directly we have to use prednisolone, not prednisone. So of 5 mg of prednisolone is equivalent to 1 mg of Dexona, and hydrocortisone of about 20 mg. So this is the equivalent dosages. This is first thing. Then coming to the rationale or mechanism of action of all these things. So mechanism of action. See, when we are considering steroids, there are two things. One is glucocorticoid action and mineralocorticoid action. So glucocorticoid is mainly related with reduction of inflammation. So it decreases inflammation. Whereas mineralocorticoid function is related to retention of salt and water, in turn aiming at increasing mean arterial pressure. These are the two basic fundamental things regarding mechanism of action of steroids. Now here comes various drugs. For example, first thing is if we consider hydrocort. So this drug has 1:1 mechanism of action, that is it has both glucocorticoid as well as mineralocorticoid action. So it will reduce the inflammation as well as it has the capacity to retain salt and water, leading to increase in volume status. So this drug is used in septic shock. As we can see, in septic shock there will be sepsis and background inflammation will be going on. So this will decrease the inflammation, and the shock part will also be recovered by increasing mean arterial pressure. Here we can think that by decreasing this inflammation, will it lead to flare up of sepsis? No, it will not, because this hydrocortisone will decrease inflammation to such an extent that it will not flare up. Sepsis. So though it is decreasing the inflammation, it is not that potent to suppress the inflammation. And here one more thing is, we have to remember the half-life. So half-life is about 12 hours. So we can consider hydrocortisone as a short-acting steroid. And as the half-life is about 12 hours, we can give maximum TID in a day, 3 times a day, 2 to 3 times a day. And one more important thing is, as it is short-acting, there is no need of tapering of hydrocortisone. Then next thing is, after hydrocortisone, same points we will consider about methylprednisolone. Methylprednisolone. Here it has 5:0.5 ratio of glucocorticoid and mineralocorticoid action. So it is very good at decreasing the inflammation, but it is not that potent enough to retain salt and water. So we can use in volume overload state also, without any fear of having excess volume overload. Again, though this is a potent inflammation suppressor, it will not suppress to that extent to flare up, no flare up of sepsis. This thing we have to remember. And coming to the half-life, T-half is about 36 hours. 36 hours. So we can consider it as intermediate acting. Hence, whenever we are using methylprednisolone, it needs tapering. This is about methylprednisolone. Similarly, all these points will apply to prednisolone and prednisone also. Then the third thing is about dexamethasone. About Dexona, the glucocorticoid and mineralocorticoid ratio is here, it is about 25:0. So dexamethasone is completely having glucocorticoid action but no mineralocorticoid action. So there is no risk of retention of salt and water leading to volume overload, but it suppresses the inflammation with high potency. So it is used in life-threatening inflammatory conditions such as meningitis, even dengue, fever, and laryngeal edema, etc. But one thing we have to remember here is this will suppress the inflammation to that extent that it will flare up sepsis. So we have to be careful, or we should not use dexamethasone in case of sepsis. And its half-life is more than 36 hours. So we can consider it as long-acting steroid. Again, in such cases, it is very difficult to reverse its action when required. So this is about the mechanism of action of various steroids. Then comes dosage. So normally in textbooks, we will observe that the dosage is based on the prednisolone. So they will mention that we can use, third thing is dosage. Often mentioned thing will be like 0.5 to 1 mg per kg body weight per day we can use. So suppose we consider an individual of about 60 kg, it will come to about 60 mg of prednisolone or prednisone. So this will be the dosage. And similarly, if we are having methylprednisolone at that time, or dexamethasone or hydrocortisone, we have to utilize this equivalent dosage and convert accordingly. Then only we have to use. No random dosage should be followed here. So this is the important thing. Then comes some special scenarios. For example, there is something called as pulse therapy. Pulse therapy, here we will use very high dose of steroids for short duration. Commonly, methylprednisolone of about 1 gram per day is used, especially in case of lupus nephritis or some inflammatory conditions of the nervous system. We will use this, especially in demyelinating diseases also, and acute transverse myelitis, etc. So this is one thing, but here there is no need of tapering. See, one thing is we have to consider the half-life of the drug used. If the half-life is long, we have to consider slow tapering of the medication. If the half-life is short, no need to taper it. Then comes in relation to steroids. If you use steroids for more than 7 days, then only consider tapering. Otherwise, no need. So pulse therapy will be often given for 3 to 5 days only. So no need to taper it. Then what is stress dose? Suppose the individual is already on steroid for some condition, and if they develop minor stress or illness, at that time we have to follow 3:3 rule. That is, we have to use 3 times higher the present dose for 3 days. So 3 times higher dose for 3 days. This is stress dose of steroids. So these are the things which we have to consider when we are using steroids in medical cases. And few side effects which we should not forget is renal injury, of course, cardiac toxicity, then osteoporosis and proximal myopathy. So these things should be kept in mind when we are using steroids. Hope it helped. Thank you so much.